Welcome to BCRF Zoom. I'm Margaret Flowers, and we're joined today by Dr. Fergus Couch, BCRF investigator from the Mayo Clinic in Rochester, Minnesota. And we've asked Dr. Couch to join us today to tell us about a paper that he and his colleagues have just published in the New England Journal of Medicine. And the paper looked at the association of genetic or inherited genetic mutations in breast cancer susceptibility genes, including the BRCA genes, but as well as some other less known genes. And interestingly, the study included not only women who are a high risk for breast cancer based on their family history, but also women who would not be considered a high risk because of a lack of a family history in breast cancer. So, Dr. Couch, I'd like to begin by welcoming you and asking you to briefly introduce yourself to our Zoom audience and set this up for us by telling us a little bit about your BCRF research and how it relates to this current study.
Thank you, Margaret. Well, it's a great pleasure to tell the audience here about this new manuscript. I've been a member of BCRF for a number of years now, and my focus is really on breast cancer genetics and understanding the genes and the mutations in the different genes that can predispose or increase the risk of women to get breast cancer. So a lot of my work over the last number of years with BCRF have been looking at individual mutations. But in this case, we started a project about 4 years ago where we realized that all the risk estimates for breast cancer that were being given to women were either focused on BRCA1 and BRCA2 alone, as you already mentioned, and didn't really focus on the other genes. And there's now essentially 12 genes that are accepted as predisposing genes for breast cancer. BRCA1 and BRCA2 really being the most common. But we realized that, first of all, a lot of the studies were focused on BRCA1 and 2 only, or when they did focus on the other genes, they were really all about high-risk patients. And when we talk about high-risk patients in the genetics community, we're really talking about people with a family history or a particularly early onset of breast cancer, such as breast cancer at age 40. And in looking at the literature and thinking about our field, we realized that there were really no estimates for women that didn't have such a family history or a young age of onset. So in other words, there's a large group of the breast cancers that we see every day of the week, that are diagnosed every day of the week, that just weren't being evaluated, and there weren't any numbers. So if one of those women happened to get tested and a mutation was found, they were given the same risk estimate as for breast cancer and for other cancers and for a second breast cancer and other measures like that. They were given the same risk estimates as essentially the BRCA1 and 2 carriers from the high risk group, right? The people with the family history. And we've seen other studies that have been published recently saying that when you do all breast cancers in the community, 30 to 50% of the mutations overall are not in women with a family history. So we have all these women being given these inflated risk estimates for mutations in these genes that really probably have lower risks because they don't have the family history, and there's other events such as the environment or other genetic factors that mean that they have a slightly lower risk. So we embarked on this very large study called Carriers, to look at the general population of breast cancers. And the approach was to contact very large studies around the United States who had these huge collections and had followed them over many, many years. And they had thousands of women with breast cancer and then thousands of women who were unaffected but were recruited into these studies at the same time and followed just the same way as the people who got breast cancer. So they're very nicely matched. That's the term we like to use in our work. They're matched nicely. And that allows us, when you have populations like that, you can actually come up with fairly accurate risk estimates. So we managed to gather in about 35,000 DNA samples from women with breast cancer and about 35,000 matched unaffected women from the same studies, took the DNA into our lab and tested them for the mutations in these 12 genes. And we did a few other genes as well, but that's not really pertinent to today's discussion. So when we looked at these 12 genes and we ran across these 70,000 women over a period of about 4 years in the lab, we came up now with new, what we call frequencies. So what is the prevalence, or how common are the mutations in the different genes in women from the general population with breast cancer and in unaffected women from the general population? And the take-home message was that about 6% of women in the breast cancer community have mutations in these genes. And again, only about half of those would have any kind of a family history at all. And really only about 25% of them in our study would really stand out as having a high risk and really having a very significant family history of breast cancer. So again, fully 75% of these women would not have fallen into that high risk category. So 6% have mutations, and then even 2% of the unaffected women had mutations in these genes. So there are many women walking around in the United States today, walking around all over the world today, who have mutations in these genes, are at elevated risk of breast cancer, but don't know it, simply because we tend to select women for testing based on their family history. And in this case, many of them don't have that.
Okay, so I think what everybody's going to want to know is how does, having one of these mutations, if say a woman who is considered not at a high risk, and let's assume that this study leads to a more general risk screening, genetic risk screening in the population, and a woman is found to have one of these other breast cancer genes that not as high prevalence. How do we know how much her risk increases with that? So when we think about risk prediction and personalized risk prediction, is there a way from does this study sort of set up that kind of an algorithm that can more precisely tell a woman what her risk is based on what you've learned?
Yes, yes. So as well as figuring out how common the mutations were in these different genes, we were also then able to estimate risks. So for each gene, we can say that if you have a mutation in this gene, the approximate risk is a certain value. And what we found across these genes is that the risks in the general population of breast cancer women are a little bit lower. And when I say a little bit, I do mean that. They're not tremendously lower, but they're a little bit lower than what we would see in that high-risk population. What that does not do, in our opinion, is really change the management guidelines and the risk management strategies for these women. We don't see genes. So many of the women who find mutations in these genes who are unaffected qualify for additional screening, so mammography and MRI every 6 months. In this case, our numbers would not pull a gene out of that category. It would still be in that category. So I think that's important to get across, is that we're not changing the risk management strategies for any of the women with mutations. But what we are doing is providing more accurate risk estimates. Because if somebody quotes a number such as 30% risk lifetime to you, the next woman I talk to, a 30%, that 30% means something very, very different, right? Some people encounter that and look at it and say that's a very high risk, and other people interpret it as very low risk, and everybody has a different impression. And so by giving these new numbers, we just give more accurate information to the women so that they can decide what they want to do. Again, for certain genes like BRCA1 and 2, many women will undergo prophylactic surgeries. They'll have breast tissue removed, ovarian tissue removed to reduce the risk of getting these cancers. For some of the other genes, we really don't have surgical intervention guidelines like that. What we really focus on is the management and the risk reduction just through screening, etc. But nobody has fallen out of a category. We're just giving better estimates so people can use that. And then that information, I think, will go beyond this paper. Obviously, it'll now be used in the clinics, I think, around the country for women who don't have a family history. So when a woman walks in to see their doctor, if they have a mutation in one of these genes, if they've been tested and they have a mutation, they'll fall into one of two buckets: the high-risk women with the family history, the people without the family history. And we're now providing the numbers for those women without the family history. In addition to that, as you know, Margaret, there's been a lot of discussion about population-based testing, potentially testing all breast cancers, potentially even testing all women over 30 for mutations in these various genes. And I think the numbers that we're providing here will be quite informative for those discussions. We're not making any decisions or making any statements about those ideas at this point with this manuscript. We're just providing information, and the other people who are having those discussions can factor that in.
Just to kind of, I know, these are less well-known genes, but what are these genes that you're talking about? The other genes that are not the BRCA genes? What are they?
Yeah, so there's one of the probably better known ones is now called PALB2. And PALB2 has recently been shown to be another high-risk gene. So really it is in the same category as BRCA1 and 2. We now think of BRCA1, BRCA2, and PALB2, because when you have a mutation in PALB2, your lifetime risk of cancer can be as high as 50% rather than 50%. So very high, much like BRCA2 itself. So that's one of the more important ones. It's not as common as BRCA1 and 2, but certainly very high risk if you have a mutation. The other ones that come up very commonly are CHEK2 and ATM. And these two are seen in about 1% of breast cancers each. So they really are as common as BRCA1 mutations. But again, the risks for those genes are quite low. It's maybe 20 to 30% lifetime risk of breast cancer in that setting, much lower than the 70% that we give for BRCA1. And in that case, as I said earlier, the guidelines currently focus on screening with MRI and mammograms and not really surgical interventions or anything like that. We don't think of the risk as being high enough to merit that. Again, remember the general population risk is about 12% for all women walking around on the street. It's 12%. So we're going to 20 or 25. It's really only doubling of the risk. So certainly it merits additional screening, but maybe not the surgery. And then there are no real therapies when people have breast cancer and they have these mutations. We know that, for instance, BRCA1 and 2, and now there's information saying that PALB2 as well, can all be treated in the metastatic setting for breast cancer with PARP inhibitors. That's really recently been established. But these other genes, ATM and CHEK2, it doesn't look like those drugs work for those tumors. They won't work against CHEK2 and ATM tumors. So we are on a search then for additional therapies that might be more targeted in that way.
Mm-hmm. And some of the other genes that you looked at are more in the very rare category.
Correct. Yeah, we have RAD51C and D, which are actually better known as ovarian cancer genes, but they do cause a little bit of breast cancer as well, and a few others that are just super rare, less than 1 in 1,000 breast cancers. So, I won't get into those. I'll just focus on the more common ones.
So, do you foresee then that as you said, this sort of adds to the discussion about, the population-based screening for inherited mutations to better assess risk and how to personalize breast cancer screening for individual women. Would you foresee that this would be sort of a panel of genes that would be sort of like a standard genetic risk assessment? I think what I'm getting at is we know that there's so many genes and variants that have less variants of unknown significance, I think they're called, because we don't really know what their impact is. Yet we haven't determined that, if there is any. And there are some gene panels that are so huge. And what do you do with all that information? If you can restrict a gene panel to this, maybe 12 or 14 genes, you'd be able to get an accurate prediction of a woman's risk.
Right. So the testing companies that offer screening for mutations like this in predisposition genes have focused on really building panels that have many of the genes that would cause several different cancers, right? So you might have breast, ovarian, prostate for men, right? They'll all colorectal cancer, endometrial cancer, all those genes will be on the same panel together. It's just more efficient for the companies to screen them all at the same time. So I don't see that changing, to be quite honest. I think they'll still offer those same testing products for people to get tested. The complication, as you've pointed out, is how do you interpret the result? If you get a mutation back in a gene that has nothing to do with breast cancer, is somebody going to misinterpret that and say, oh, you do have an elevated risk of breast cancer because I found this mutation? The answer may be no, you don't, but you might have a risk of something else like colorectal cancer. So in some ways they're informative because they might speak to other risks of other cancers that you might have. The VUS question then is very well taken. If you have a panel of 84 genes or something like that, you're going to find mutations somewhere in some gene. Many of those genes on those bigger panels really have not been implicated in any cancer. And so it's just confusion, right? There's just this multitude of mutations that are found that nobody really knows what to say or do with them. The focused interpretation of these 10 or 12 genes for breast cancer is a lot easier, certainly for the physicians to deal with, and then to pass that information to the patient. So certainly it would, I think, make sense from a breast cancer and an ovarian cancer perspective if we could whittle it down and narrow it down to just the key genes. But really, I don't see that happening because of the way the companies do their business, right? They need, from an efficiency perspective, they need to do a big batch of genes all at the same time. But there are complicating factors as a result, which is VUS and mutations we don't understand.
Mm-hmm.
Yeah.
So what is your take-home message based on this, on the results of this study?
Right. So the take-home message is that we now know that these mutations are actually very common in the general population. We now know the risks that should be given to women when they don't have a family history, when they're diagnosed with breast cancer. And we also know the risks in the general unaffected, women who don't have breast cancer yet, the unaffected population. We do know the risks there if people get tested and are found to have a mutation. And I think that's going to be very valuable going forward as people then embark upon risk strategies, risk management strategies, and just understanding their personal risk. And then I think this information will be merged with other emerging risk factors. Margaret, you're aware of the so-called polygenic risk score that's coming out now. That is another genetic test that can be done and can be combined. People are starting to combine that with the information that we're generating, where you have two different genetic tests that can work together to even more precisely give each woman her own risk estimate rather than a global sort of risk estimate. And then the one last thing I'd like to point out is that one important part of this entire study was that it was not just focused on white women or non-Hispanic white women, whichever term you want to use. We did have Asians, Hispanics, and African Americans in this study as well. And so we were able to come up with estimates of how common the mutations were there, and indeed risk estimates for those populations as well. So I think that when I said general population, I really did mean it. We tried to get a smattering of the entire broad spectrum of our population here. And this information then can be passed on to all those populations.
Did you, just on that note, did you see that in those other populations, were there specific genes that maybe stood out in one population versus another?
Yeah.
Were there specific genes that were related to specific types of breast cancer versus others?
Right, exactly. So overall, the mutations, if you take all the genes together, then the rate of mutations or the frequency of the mutations overall across all those genes were about the same across each population. And that's good to know, right? Because then we know we can apply the same panels to everyone. But then in specific populations, there were certain genes that were more common than others. So a prime example of that is the African-American population. And we know the African-American population has more triple-negative breast cancer or ER-negative breast cancer. As much as 30% of the women will get triple-negative breast cancer there, whereas it's only maybe 12 to 15% in the white population. And as a result of that more common triple-negative breast cancer, we do now know that there are genes that really just drive only ER-negative or triple-negative breast cancer. And those would be those RAD51C and D genes that I talked about as being ovarian genes, but they're also now known to be triple-negative genes as well. And so those mutations were more common. We also saw more BRCA1s because, of course, that causes triple-negative breast cancer. But then on the other side, there were less ATMs, CHEK2s, BRCA2s, which all tend to cause ER-positive breast cancer. So the frequencies or the prevalence of each type of mutation is going up and down a little bit across the populations, depending on how the population presents with breast cancer. But overall, it's the same. And therefore, we know that the testing procedures we use today are effective across all populations, which is great news. You know, that really makes the physicians more comfortable going ahead and ordering tests for any woman that shows up for care.
I think very important point indeed. And one thing that I wanted to talk to you about is you mentioned the number of women that were in this study, and of course the consortia, the carrier study combines a lot of different studies. And one of the things I wanted to ask you was why is it important to have so many groups combined, these large consortia studies to do these kinds of genetic analyses? And I'm going to answer my own question, but I think part of it is because you're able to see trends in populations that make up fewer of the individual studies. Is that part of it?
That's certainly true. The other part is just the basis of statistics, right? If a mutation, a certain type of mutation is only found in 1 in 1,000 breast cancer cases, you need 35,000 breast cancers to get any kind of certainty about how common mutations are in that gene. So it's a numbers game in reality. We just need these huge numbers to get certainty around some of our estimates. There are other large studies that are similar to this. There's a big study coming out of Europe that's very similar to our own that will come out in the same edition of the New England Journal of Medicine. And it turns out that their numbers are actually very similar to ours. So they're European-based, we're US-based, and yet the numbers are very similar. So that's great to see as well, some verification or validation of the findings. But again, their study was huge as well. Many, many thousands of women involved in these studies. But it's all about statistics. That's what it comes down to.
Right. Well, I mean, it's definitely an important step forward in our understanding of genetic risk, as well as it helps to explain some of the trends that we see, particularly as you mentioned, the ER negative breast cancers that are more frequent in African American women compared to white women, and that certainly helps to explain that. Yeah. I want to thank you so much for joining us.